welcome to our Department of Health mock survey follow-up and service. I'm going to be going over some of the areas that we found needed review. So our objectives, and I'll read the ones related to the session I'm going to be doing. For the first thing is to understand the clinician's responsibility to perform a complete drug regimen review and med reconciliation.
And then identify items that belong in the clinical bag and how to use correctly, as well as describe basic concepts of infection control, including importance of universal precautions, hand hygiene.
We're going to go over and make our objectives of understanding the importance of compliance with HIPAA, and including how to safeguard PHI or protected health information, and also understand regulations regarding the patient's right to make a complaint.
Okay, so I'm going to start with the drug regimen review and med reconciliation. And I'm going to preface this by saying that this is a condition of participation. Okay, it's not just something the VNA wants you to do. And the conditions of participation, remember, are rules that we have to follow in order to get reimbursement for Medicare and Medicaid patients. Okay, so we're going to talk about some of the basics. This is just review, and it's just to reinforce what you as clinicians need to do to reflect that you've done this. So the drug regimen review is related to the OASIS question, that M2001, and it includes reconciliation of all the meds the patient's currently using and review of the drug regimen to identify if possible, prevent potential clinically significant med issues. And what is a potential clinically significant med issue? It's a potential or actual issue that in the clinician's professional judgment, now remember this is in your judgment, okay, that would warrant the physician be notified. So if you think the medically or potential medically clinically significant drug issue is something you would have to call the doctor about, that meets the definition. And what's the med rec? It's creating the most accurate list of all the meds the patient's taking, comparing that list to the MD orders from the referral, and then the goal is to provide an accurate, correct list of all the patient medications that they're supposed to be taking. So these are just some examples of potential or clinically significant med issues that you could encounter. Okay, adverse reactions to the meds such as a rash, ineffective drug therapy, an analgesic that's not managing their pain, side effects, potential bleeding from an anticoagulant, drug interactions, which we're going to go over a little bit more on another slide, serious drug-to-drug, drug-to-food, and drug-disease interactions, duplicate therapy, generic and a brand name, potentially being taken at the same time, omissions, drugs not in the home, refusing to take that drug, dosage errors, too high or too low, non-adherence, purposeful or accidental. I know this is nothing new to you, but it warrants review because we're not doing the best job we can be doing on med reconciliation right now. So we're going to go over 3 steps in that process. The first thing is to verify. We're going to collect an accurate and complete list of all the medications the patient's currently taking. What are they putting in their mouth today, the day I'm doing that? The next step is to clarify any questions about the drug dose frequency, purpose, or potential side effects. And the last step is to reconcile, which means you communicate with the physician about all med discrepancies or clinically significant issues. So let's talk about that verify step. So you're in the home. The best thing to do is let the patient know that you're going to have to go over their meds and to please have all their medications ready when you get there. That'll save a little bit of time. You go over all the meds, and that includes everything: prescription, over-the-counter, herbals, dietary supplements, vitamins, etc. Okay, it's everything that they are taking, not just the prescriptions. The next step is to clarify any questions they have about the dose, frequency, route, how to administer, potential side effects. And you're doing this so that you can create an accurate entry of the meds in point care. Okay. The next step in the clarify step, and this is very, very important, is that you're identifying in this step any serious drug-drug interactions or potential clinically significant med issues, which we've just gone over with that list of examples. If a possible drug-drug interaction is present when the patient's, it is present when the patient's meds include 2 or more meds with potential to interact negatively with one another. And you know that point care flags these interactions, and you'll see them as a level 1 or a level 2. Okay? So we'll go over that on a subsequent slide as well. And the final step is to reconcile. I think this is the step that we all need to work a little bit harder on, and you may be doing it, but I think the important thing is the documentation that you're doing it. So we communicate with the physician all of those clinically significant med issues, drug interactions, medication discrepancies, and clarify any questions or concerns. You're actually responsible for ensuring that these are reported to the physician and obtaining clarification or revised orders. Therapists, I know you're all sitting there going, oh my goodness, but you know that your responsibility, excuse me, is to document all of this in your therapy drug review coordination note. Okay, that's your responsibility. You have the ability and the skills to identify all of this. Your responsibility is then to document that so the drug regimen review nurse can follow up with the physician and get those clarification of orders. Okay, that's very important. Okay, so let's go over your role. All right, so for those OASIS events, the SOC, rocks, and research, okay, you are completing a drug regimen review and med reconciliation. There's no doubt about it. You have to do this. Remember, it's a condition of participation. So again, at the stock or rock, you're comparing what the patient is taking with the medications that are ordered on the referral. And you know those med lists should be in the attachments. And if there's more than one, try to use the most currently dated one when you're doing the med rec. I'm just going to point out, if it's not there, please ask for one. And we're trying, we can help you, intake can help you, your managers can help you. On research, you're supposed to review the med list that's in the record and verify that that med list is still what that patient is taking. If that med list is being updated throughout the episode, there won't be anything to do on a research because it should be accurate at that point. But you still have to do it. If there are any changes, you still have to reconcile those changes with physicians. Okay, if there's a change in dose, or if they tell you, oh, the doctor told me I could stop taking med A. You still have to reconcile and get a verbal order for those, and then you have to document that you've gotten that. If there's a new prescription bottle in the home, you can put it in the record, and you must put in the comments or the instructions box, right, that medication was verified with a new prescription bottle in the home dated. Okay, in that instance, you don't have to call the physician because you have a brand new prescription that they just ordered in the home, just to make sure that you've documented that in that instructions box. Okay, so you document the telephone call to the physician to clarify, get new orders, you document the physician's response when it's received, and you update the med list with a new order in point care. Okay. And therapists, again, you can contact the drug regimen review nurses. If you do a therapy drug review note during an episode, you'll have to let them know because there's no triggers that we can pull up for that. They do it with the SOC, rock, research, OASIS audit report every day for therapy only, so you'd have to let them know. The next slide we're going to talk about is the drug interaction slide. And I think this is just one thing that you all deserve clarification on because I don't think we've ever come out and really said that for all level 1 drug interactions, the physician must be called, okay? You all have to call the doctor for your plan of care confirmations for all those OASIS events. Okay, so during that call, you're going to notify the doctor that there is a drug interaction between whatever the two meds are, and could they please get back to you with a reply so that we have that back and forth communication. So it shows the doctor got it, and sometimes I know you hear that the risks outweigh, the benefits outweigh the risks, so that you really don't have to change anything. But we have gotten some feedback from the physicians to tell them to stop taking that med. So those are the kinds of follow-ups we need to hear about. Okay, you document the MD contact on the med interaction coordination note, which auto-generates in the system. Okay, but we have to be really careful what we're putting in there. That documentation should be documented where you see OK up here. Example, telephone to Dr. Smith, spoke with Mary RN, notified about level 1 interactions, and be specific. Request review by MD and return telephone call instruction. Spoke to Dr. Costello, notified about the above level 1 interaction, MD aware, and no change in medications prescribed. What I have seen over the years in that note are what follows. No change in regimen has been made since the hospital. That doesn't mean we've called the doctor. MD notified, MD aware, Nexium as needed, these are actual examples. Pharmacy aware, PCP aware. That doesn't say that we've done what the conditions require us to do, which is notify the physician of those issues with those interactions, okay? So we're due for our New York State Department of Health survey, which is why we're doing all this, which is why we did the mock survey. So we want to be prepared with all of that documentation. Make sure you document the MD's response again and make any changes that are recommended with a new order in the record. And just as a note, when we get your workflow, starts, rocks, we have a stage that we push things through very, very quickly, and that's within 24 hours of that, when that's sunk in. So first thing every morning, one of my girls does that first workflow, and during that time, they look for the drug-to-drug interactions, and they fax those reports to the physician. So the physician is getting a copy of that. But for level ones, you must call the physician, okay? And finally, with each visit, so that we're maintaining an accurate med list in the home, you're going to ask the patient, have there been any changes in your meds since the last visit? And you know that this is part of the care coordination section of the visit note that kind of compels you to ask that question each visit so that we can keep an accurate note. And the process is the same. If there are any changes, you notify the physician, you document you notified the physician. If you get a physician response, you enter whatever changes, or just document physician is not indicating the need for any changes in the record. Any questions? We're gonna do questions at the very end, so I think we decided we would hold all questions till the very end.
Yeah, just to make sure
We get everything in, yeah,
So-
okay.
So then into the infection control portion, so this is just a list of what is included in your clinical bag. The asterisk items mean that they're included in the non-nursing or PT bags as well. So there's alcohol-based hand rub, alcohol wipes, BP cuff and staff, CPR pocket mask, disposable aprons, disposable bag barriers, gate safety belt, hazardous spill kit, headlamp, liquid soap in a bottle, lubricating jelly, mask with eye shield, non-sterile gloves, paper towel, pen / flashlight, sandy cloth, sharps container. It's not actually kept in the bag itself, and then sterile gloves, sterile Q-tips, tape measure, thermometer, and tongue depressor. So this is given when you're initially start with your clinical bag. And then there should be at least 2 pockets, a clean pocket, a dirty pocket. There's actually more compartments in the bag than that, but in this dirty pocket, you want to keep your soap, your paper towels, your alcohol-based hand rub, your barrier, your apron, your non-sterile gloves, your alcohol wipes, the sandy cloth, and then in the clean pocket, craft your materials, your BP cuff, your staff, tape measure, has spill kit if you have that, a CPR pocket mask, a trash bag, scissors, needle, vac container, and tourniquet. And then I always just thought it's good to keep the clarification of why are hand washing materials kept in your dirty pocket. It's really because you need to have clean hands in order to enter the clean pocket. So you want to think you go from dirty to clean. In order to get those materials, you gotta clean and then enter the clean pocket. So, and then other items that you may need or may use for therapists, goniometers, OTs might have, or speech might have small assistive devices, or even the home health aides. We thought of the nail filers they may have, so that would be in your clean pocket. And then, so basically, it's kind of common sense. If you can't clean the item, do not reuse it. Safer to give it to the patient or the caregiver rather than put it back and risk for potential exposure. And then steps in using the bag correctly. So this is right from our policy. Same with the other slide too. You want to place the bag on a clean, dry, firm, flat surface. If there's no clean surface, you preferably hang it on a doorknob or the back of a chair. somewhere where you have access to it. You want to wash your hands with soap and water or for 15 to 20 seconds, or if you're using an alcohol-based hand rub until dry. You want to remove the clean supplies needed from your clean pocket and place on the barrier. You want to then provide care, but never enter your clean area of the bag until the hands are sanitized. So, and then this is big because I feel that sometimes we forget as clinicians to completely zip the bag, and DOH would kind of pinpoint that. So just kind of underline that you want to zip it until you're fit. You want to zip the compartment, you know, once you're not entering it, to because you don't want to risk exposing it. So the thought is, if it's fully zipped, nothing's going to come in or out, or you're not going to risk going in there. And then if you do have to go back in, you'd want to at least sanitize. And then once you're complete with care, clean your equipment. So another thing that DOH likes to cite on, not just our agency but other agencies, is cleaning our equipment. And we tend to forget tablets, we tend to forget even cell phones. Some people may not make a call right then and there while they're in with their materials, but if something does come up, a doctor calls you back, or you know, and you have to take the call, you'd want to at least show that you're cleaning it, or verbalize that you're going to clean your equipment. And then, you know, so you want to do that before you return it to the bag. You don't want to do it once you're in your car. I mean, it's kind of more easier to do that, but then think about it. If you're risking, there was a study, I want you guys to know this figure, that like, it was a different state, not New York State, but they studied where most of the contaminants lie, and it was like 20% were outside the bag and 80% were in the bag. They found MRSA, VRE, all sorts of nasty stuff in clinical bags in general. And the risk of that is putting something that you didn't clean in or let it dry back into your bag. You know, you're potentially exposing not just the patient you're with or that you were you know, exposed from, but to the next patient. So just be mindful of it. And then any barrier that you did use, you want to dispose of it, fold it with dirty side in, and dispose in the plastic bag. It is okay to place in the patient's trash can, but you want to clean your bag regularly. So our policy states that you want to clean the clinical bag. It says every 3 months. I've seen other places every month, you know, but use your discretion. Ours are, they don't have, I forget the name of the cloth. It's not open cloth, so you can use bleach on the bag if you needed to. It's not a open pore. It's not a porous surface. So, and then the other thing is, you wouldn't want to take the clinical bag in for homes that you know are going to be, you know, patient on contact precautions, or if you've been there and you've witnessed it's not clean, or potential bed bugs, or something that could potentially put your bag or you know, more in jeopardy. So just be mindful. And then I just thought it'd be helpful, I don't know if you guys think about universal precautions. The concept is that we as healthcare providers treat all fluids, all patients that we're with as potentially infectious, we'll be less likely to carry because we can be a carrier ourselves, our bag can be. So you want to decrease your exposure. So how do you do that? You treat anybody by, you know, washing your hands, or using alcohol-based hand rub, and you know, gloves and protective barriers if necessary. And again, use PPEs, and that's to prevent contact with bloodborne pathogens or opiums or other potentially infectious materials. And then another thing, we're not really, not all clinicians are exposed to this, but follow sharp safety. You never want to recap a needle if you are using it. You want to make sure your sharp spin isn't overflowing. Our policy, I believe, states 3/4 full, that we take it here. We actually have a contract Michelle works with that they pick up. It's either once or twice a month, I believe, to get rid of any sharps that we do bring on site.
Can I just say, we don't bring sharps from the patient's house, and to educate them how to dispose. So if somebody wants to hand you nurses, it would really affect.
That's
You
a,
don't bring them back here, you educate them where to get rid of them in the community.
yeah, most CVS, thank you, Fran, most CVS or Walgreens or pharmacies do have sharps disposal.
Has a way you can drop stuff off.
Yes.
We can Google it for you.
Yeah, and really it's to prevent us from risk or exposure in that scenario.
And the cost.
Yeah, exactly, so, being conscious. And then lastly, vaccinate, we're offered Hep B upon hire, so, these are just things that the global literature states what to do to mitigate or, reduce exposure. And then lastly, just an overview of infection control prevention. So hand hygiene is the #1 most important practice to reduce transmission of infections in any healthcare settings. We had a discussion when I first started. I remember Fran and I talked about alcohol-based hand rubs. They are okay to use as long as your hands aren't visibly soiled. And at that point, if your hands were visibly soiled, you'd probably want to be wearing gloves anyways. So, and then standard precautions applies to everyone. That's how you kind of remember it. So wearing your gloves if and when contacting blood or body fluids, performing hand hygiene. It's before or after glove removal, and then wearing gown to protect skin and clothing if you're at risk for more splash or exposure like that. And then respirator masks if a patient is TB. In all my time here, I haven't had anybody. There was one case that we were potentially gonna isolate, but we didn't need to, so just be aware of that. And then again, cleaning reusable equipment, not just your steth, but your tablet, your devices. And then just really quickly, transmission-based precautions. So what are contact precautions? We use that for antibiotic-resistant organisms, so your C. diffs, your CREs, your MRSAs, your VREs, and then droplet precautions is used for flu, any respiratory MRSA, if it's not just MRSA in the blood, but in the respiratory stream, rubella, mumps, pertussis, and then airborne is for TB, measles, chickenpox. So, and then just finally, I put this slide in here because we're realizing at some point later in the year, we've been talking about PDGM, patient-driven groupings model. It's going to be coming to all home health, and actually October 1st, it's coming to the SNFs even sooner than us. And so we just wanted to give just a quick overview to our staff right now what it is. So we created an executive summary for our outside bodies that we work with to help them understand it. So really simply, patient-driven groupings model. The big change is it's going to create a 60-day home health episode into 2 30-day, they're calling it periods. So it's still a 60-day episode, but it's 2 30-day periods, and it's more for payment. It is effective January 1. So this model will change reimbursement from therapy-driven to diagnosis-specific. So that's why really the focus is on getting the right information at intake referral. So that way we are codifying with our vendor Quirt right now currently to make sure that the record matches. So that way when we do get to billing and they're submitting our claims for us, the codes match, and CMS can verify that patient had XYZ diagnoses and they were coded for it. So really the big thing is the HERG is now, there's 432 scores. And the way the HIPS code is now called is it's going to be codified into referral source. So it's either going to be, all patients are really going to be community, come from the provider, or institutional. Institutional means any patient that comes from a discharge from a hospital, anything within 14 days of discharge. After that 14-day period, any referral that we then get becomes a community referral. And the reason that's important is the timing. All episodes really initially, that first 30-day are going to be early, and then after that are going to be late, except if there was an episode within 60 days. So if, Robin, you came into our services, you were discharged, and then 15 days later put back onto service, then that would be considered a late, unless you're coming from a hospital. And even then, so because there's been an episode within 60 days, it's going to be considered late. So the way I think about it is, the first time the patient's in our care, it's early, and after that it's late, unless they've had a 60-day window without care, and then it becomes early again, and it starts over again. And then the last two groupings, the clinical complexity. So the big focus is diagnoses and comorbidities. So we can code up to, I think, 24 or 25 comorbidities on our claim. And really, the last part, the functional impairment level, the reason the OASIS is so important is because there's going to be two new questions that factor into this HIP score, and that's the risk for hospitalization and grooming. Typically, we've been focused on the GGs and the M questions and mood questions, but now there's a couple of extra ones that will influence how a patient's scored. And what that does is it shows at the start of care how functionally impaired the patient is before they come under our services and before we tend to improve them. So I don't want to belabor this point, but I just wanted to give you just a quick high-level overview of how it's impacting not just us as clinicians, but our billing department, our intake, our coding, our UR. So more to come. There'll be more training in the future before we go live, once our EHR is updated for all this. So, okay.
Stay tuned.
Yes.
It's my turn. So we've put this together based on what we determined were areas of risk and or areas of interest. So we went out on co-visits with people, some of maybe people who are in this room. And based on what we maybe found, if I was a Department of Health auditor, I would have cited us for, we wanted to educate on those areas of risk. And then, of course, we spoke to the patients one-on-one or their caregivers, and we spoke to the clinicians one-on-one to see what areas of interest. Maybe you guys out there said, well, you know, I'm glad you asked me that because I had a question about this, and this is how we put this together, just as a heads up. HIPAA was, we didn't see any HIPAA problems on the field visits, so woo-hoo, that's good news. But it is an area of risk, so we want to just briefly go over it. And the first bullet we have there is just if anybody was interested in having the reference to the regulation for themselves, to take a look for themselves, you could go ahead and do that. But basically, in effect, HIPAA is designed to what? It's designed to protect everybody's individual right to privacy and confidentiality, right? We want to avoid having information stolen, identity theft, etc. It's also designed to assure that information we share, whether it's electronic, written, or spoken, is secure. So the best way to secure to follow HIPAA and secure protected health information, follow the minimum necessary rule. So only tell people who need to know what they need to know, right? There's no need to talk to a neighbor about how Mrs. Smith is doing. It's none of their business. In regards to how we educate our patients and caregivers on this and how we prove that we've done so, well, when you do an admission and you have your admission packet, you review the notice of privacy practices and you have them sign it. So there's one layer. And we'll get into other areas as well on subsequent slides. If you see or suspect any breach of HIPAA, please notify the office, okay? You're not tattling, you're not getting anybody in trouble. You know, if you see something or hear something, you should say something. Trust me, we will investigate promptly, and if there's nothing to be worried about, then you'll find that out and we'll all take a big sigh of relief. But worst case scenario, if there is a problem, we want to be able to triage that immediately. A heads up, briefly, these are high-level points on the first slide. Really, texting, not something you want to do that includes any kind of protected health information. And we'll go over examples of that. But you know, your basic, you break out your phone and your basic SMS app, it is not secure. There are apps out there that have secure texting, and if we have one at VNA, like we used to have, I think Cortex it was called, we will let you know so that you can use it. But if we don't tell you it's approved, don't text any patient-sensitive health information via text. So HIPAA is great. It protects people, allows us to share information, timely turnaround on getting patients the care they need. The opposite side of that coin, the risk, is that there's high potential for that to be accessed by someone who shouldn't have it and to misuse it. And I'm sure you've seen in the news every once in a while, whether it's a bank or a healthcare company, they've had a breach, and there's large problems associated with that. We'd like to avoid that for our patients, you guys and us. So let's talk about some consequences. There are legal consequences. There's civil and criminal penalties that are possible. Literally, you could be imprisoned for an egregious enough breach of HIPAA. And fines can go all the way up to $1.5 million per type of violation per year. So it's a pretty severe, and rightfully so, a consequence. So what is PHI? What's protected health information? It's any information related to a person's health status, treatment, or payment for health services received by the agency which may identify the individual. So it basically reveals their identity, which could be stolen. And that it can include their personal protected health information or specific medical information. So you can see many examples up there. I think name is pretty obvious to people, but believe it or not, email address, that's PHI. Their physical address beyond the state level. Like you can say, my patient in New York State, that's okay. My patient who lives at 35 Colvin, breach of HIPAA, okay? Their health plan number, you know, their Medicare number, their CDPHP member number, those are also protected health information. Photographs, medical history, diagnosis, I think those things are pretty obvious. And then specific dates, such as their birth date, admission date, discharge date, date of death. Yes, we can say somebody was born in 1971. We can't say they were born on January 5th, 1971. So how can we protect PHI? So related a little bit back to what Ed was talking about with the bag training, if you are having no option, which you know, I've worked in the field, sometimes you have no option. There is going to be PHI sometimes on your person. We know this. We try to avoid it, but it can happen. So you want to store that in an envelope, and we can give you envelopes if you need them, and inside your zippered, closed bag, okay? So I was talking about close your bag, zip it all the way closed. Yes, for infection control, you don't want somebody's cat or ferret or whatever they have crawling in there and using it for terrible things. But you can also want it zip closed because if you have PHI, you want to secure that, right? The chances of somebody opening it up and then opening an envelope just to peek at your paper is not very likely. That also includes PHI in the branch office. I know I've talked to some people, sometimes they have PHI in here because this is maybe their base of operations, right? You know, if you're gonna have it here, at a minimum, it needs to be face down so we can't just look at it. Even so, I have been in situations in audits where we've been cited for that at other home health agencies, even though it was face down. It would have been worse if it wasn't, because, right, you can have a contractor or a cleaning service come in and go, oh, what's this? Oh, And again, it's not just the danger to yourself or to the company, but your patient's identity could be stolen. So if you're going to have PHI in the office, we'd be more than happy to give you some large envelopes. You can stick it right in there and leave it on your desk, okay? In terms of being out in the field and your tablet, if you're going to have to walk away from your tablet, you need to lock your tablet. Your tablets, to be unlocked, should require a passcode, yes? So the best way to secure it, click that button on the side if you have to walk away. So some other things that are probably a bit more obvious, and some I found a little humorous, so I left them in. I put them in there. But so never discuss or answer questions regarding your patient's condition in the presence, even of their own family or friends who they've invited into the home. If Ed was coming into my home to treat me and Roxanne was a friend I have invited over, the right thing for Ed to do would be to say, Gary, is it okay if Roxanne is here because I'm about to talk about some private, health personal information. Is it okay if she hears that, or should we ask her to maybe step away? So you want to make sure. And of course, in the world of defensible documentation, if you didn't document it, you didn't do it. So chances are that's not going to probably become a problem if they said okay, but if it was me, I would document that somebody was present and the patient was okay with that. Certainly never discuss patients with staff from another agency or facility. I think that's pretty obvious, so I giggle a little bit about it. But I would even, there are certain exceptions. Our liaisons are going to talk about patients to people from another company all the time as they try to garner referrals. Those kind of things are okay. Those are exceptions to HIPAA. But certainly me talking to somebody, a friend at the Eddy, that would not be appropriate to talk about a patient. And I'd say even further, if Department of Health was audience and they really wanted to be sticklers, even Ed and I, if we were field clinicians talking about a patient that we did not both treat, we were just like, oh, this is what happened today, using PHI, that could be cited as well. So it really, again, minimum necessary rule. Who needs to know? Why do they need to know? We don't want to discuss it as a social experiment. It's really just for care coordination. Never discuss a patient's condition or disclose PHI to your own family and friends. As tempting as that might be sometimes if we have a humorous story. Never bring family or friends to a patient's home. That's the one I left in there as I found it humorous. I don't think anybody would bother to do that. And certainly, in all seriousness, never discuss your patient in a public environment. You know, classic, you've seen the videos in HIPAA training on the elevator, online at the coffee shop. You just don't discuss your patients. Really, again, minimum necessary for care coordination or sometimes for a learning exercise we might do in the office. And that brings us to the end of HIPAA. So one brief slide about complaints, because there were questions actually from you guys, your peers out in the field. And again, I put up the regulation for reference if you're interested. But basically what the regulation says is the home health agency should, really should say must, but should record in both the clinical record, which we do, and in the patient's home folder, which we do, that the patient was provided with information regarding his or her right to lodge a complaint. And you do that in the admission packet via the Bill of Rights and the Notice of Privacy Practices that you have them sign off on. So you are actually doing that education. Hopefully you're actually at least briefly going over that information with them. But part of it is, and I'm sure you know, there's a whole part of that section that talks about complaints. So what it says in there and what we're telling our patients is, yes, if you have a complaint, we commit ourselves to doing a prompt investigation. Our policy actually says within 72 hours we need to be investigating a complaint. And generally, as soon as we get one, we're on it. It also, on that information and on the paper in the packet, it lists our office phone number / on-call phone number, as well as our hours of operation. It informs the patients that they can notify Department of Health themselves or the home health agency hotline, which is also on that documentation, if our company, the VNA, doesn't respond to their complaint. And I would say to all of you during that education, you should educate your patients and caregivers to keep the folder accessible. Yes, I know, I'm laughing too. I've done it for years out in the field, and I'll go in, I'll say, oh, where's your folder? I want to record your vitals so the next person coming in knows what's going on and see if there's new exercises, see this, see that. And a lot of times they can tell me, and then sometimes I don't know, I don't remember, my son moved it, I'm in an assisted living facility, so they took it, I don't know where it is, I get it. But try to encourage them so that when they can, to keep it accessible, because it will come in handy, mostly for them. Especially when the Department of Health rolls in and they're like, oh, they never gave you a folder, the patient is probably going to go, I guess not, I don't know where it is, right? We know. But that concludes the training, and we do want to go over the test as a group. I believe the plan was to give you some time to answer the questions yourselves, and then we're going maybe 10 minutes or so, and then we're going to take 10 minutes and go over it together. And certainly if everybody is done before 10 minutes are up, like stand up or something, let us know you're done.
One done.
Matt, you're staying for 9
Three
minutes.
done. 4 done.